Military working dogs are athletes, performance animals that must meet certain performance standards in order to continue working. Orthopedic and neurologic diseases are common problems we see in military working dogs and have their own set of signs, symptoms, and diagnostic techniques. Some subtle signs are very early indicators of disease or injury and may go unnoticed except by the dog's handler. Many of these problems become apparent only because of an inability to perform or because of a degradation in performance. In other cases, the condition may be apparent only after heavy exercise, during training, or after working the long hours demanded of military working dogs. On the other hand, the dog's drive to work can mask many early, subtle indicators, leading to diagnosis only after the condition has become a chronic problem that may have long-lasting effects. Excitement and surroundings of the clinic may make signs reported by the handler disappear once the dog is in the exam room. Temperament, tenseness, and excellent muscle development can make examinations, especially orthopedic and neurologic exams, very challenging, but the veterinarian must resist the temptation to sedate the dog at the start. You must first complete the general physical exam, the orthopedic and neurologic exams, and then sedate the dog for a more in-depth exam and further diagnostic techniques, i.e., the drawer test, the Ortolani test, or radiographs. Safety is always a consideration. No matter how familiar you are with an individual dog or how stoic the animal appears, the veterinarian or technician must always insist that a military working dog is muzzled during any exam or procedure. Rules of thumb. Neurologic disease is a primary rule-out for orthopedic disease, and vice versa. More mistakes in diagnosis are made by not looking than are made by not knowing. Cancer is always a possibility, even in young military working dogs. Panosteitis is possible even in adults, but usually occurs in dogs only up to about 2 to 3 years of age, so always make a thorough search to rule out other more common causes of lameness. Common rule-outs including non-orthopedic diseases. The forelimb. Trauma may range from simple overexertion injuries to fractures or luxations. Degenerative joint disease of any joint or combination of joints. Bicipital tenosynovitis. Panosteitis. Shoulder OCD. Elbow dysplasia, ununited ankylosing process or fragmented medial coronoid process. Bone, soft tissue neoplasia. Infections, inflammatory joint disease. Cervical spinal lesions, including trauma, intervertebral disc disease, and neoplasia, and behavioral or training related. The hind limb. Cruciate or meniscal syndrome, including partial tears. Hip dysplasia. Degenerative lumbosacral stenosis. Trauma may range from simple overexertion injuries to fractures or luxations. Degenerative joint disease of any joint or combination of joints. Bone, soft tissue neoplasia, prostatic, rectoanal, or tail diseases, panosteitis, and behavioral or training related. Goals of the orthopedic exam. Determine if the dog is lame or not and which leg or legs are involved. Determine if the problem is orthopedic, neurologic, or other. Do a thorough exam. Isolate each bone and joint starting from the toes and working up the leg. Go from the normal leg to the abnormal. Go from non-painful to potentially painful manipulations. Be sure that your findings are consistent and reproducible. Localize lameness to a specific bone or joint for your tentative diagnosis, then try to confirm by directing X-ray or other imaging examinations to specific sites. Complete orthopedic and neurologic exams are essential for meaningful discussion of a lameness case during a consult with specialists. Prescribe a specific treatment. Educate the handler and kennel master about the military working dog's condition, treatment, prognosis, and follow-up, including fitness for duty, deployability, and disposition if applicable. Signalment and history. Past problems, treatment, and response to treatment. Which leg is lame? How long has the problem existed? Any known trauma? Try not to jump to conclusions or diagnoses based on brief history and speculation. Keep an open mind. For example, Minor DJD secondary to canine hip dysplasia often becomes a catch-all diagnosis, when the military working dog really has more severe LS or stifle disease, and vice versa. Observation. At rest. Does the dog show unequal weight bearing, asymmetry, muscle atrophy, or favoring a limb? Does the dog sit straight and balanced, or is there also asymmetry when seated? Is there a limp at walk and trot? A shortened stride appears when a dog tries to protect one leg by quickly taking weight off the limb. A head bob may also be present when a dog tries to shift weight from a painful limb while in motion. The head is raised to take weight off of the lame front leg when it is on the ground. The head is lowered when the normal front leg is weight-bearing. The familiar phrase to help remember what is happening is down equals sound. Tail carriage can give similar hints about localization of lameness on the rear legs. Thorough routine physical examination. Looking for systemic diseases that may manifest as an orthopedic problem or cause generalized weakness that may present as orthopedic or neurologic disease. Pay special attention to lumps and bumps, especially in older dogs. Palpate for asymmetry, atrophy, swellings, sensitivity, and heat. Palpate the spine of the scapula to detect atrophy of the shoulder muscles. Compare your finding on the lame leg with opposite presumed normal leg. Judge the circumference of thigh muscles on each rear leg to detect asymmetry due to muscle atrophy. A neurologic exam is also important. As a minimum, check for conscious proprioception, withdrawal, abnormal reflexes, and decreased muscle tone. It is also important to determine if back pain is present. While supporting the body, flex the dog's back and extend the hips. Also lift the tail. If any of these are abnormal, a more complete neuroexam should be done before proceeding. Some animals may need to be observed working in order to mimic the complaint, so observing the dog on the obstacle course can be very helpful. Bone and joint manipulation. Gently flex and extend each joint before stressing it in order to feel for normal range of motion, crepitus, swelling, or effusion. To complete the orthopedic exam, the dog is restrained in lateral recumbence. Start with a normal limb and work your way around to examining the lame limb last. Squeeze the periosteum, not muscle, of each long bone at the distal, middle, and proximal sites to check for increased sensitivity that may be consistent with panosteitis. Begin at the tips of toes and work up to the shoulder hip. The toes. Flex and extend each digital joint. Lateral stress is used to demonstrate abnormal laxity. Look for swellings or discharges around nail beds or in the interdigital space. Examine the pads for abrasions that may signify kennel injuries. To prevent being fooled, it is important to note that some dogs have sensitive toes or feet and will consistently overreact to manipulation on all 4 feet. The sesamoids. Flex and extend the metacarpal phalangeal joints while putting pressure on the sesamoids at the level of the metacarpal metatarsal pad. The metacarpals and metatarsals. Squeeze the paw with moderate pressure. This will usually cause discomfort if the source of pain is in the foot. This is known as the ring effect, because the discomfort can be mimicked by the squeeze of a very firm handshake when one is wearing a large ring. The carpus. Flex and extend. You should be able to touch the toes to the palmar aspect of the forearm. Also palpate for any swelling due to trauma or inflammatory joint disease, crepitus, or instability. The elbow. Palpate for medial and lateral humeral epicondyles and the head of the radius. 2 bumps laterally, 1 bump medially. Feel for a fusion between the lateral epicondyle and proximal ulna. With the elbow and carpus flexed, use one hand to put pressure on the epicondyles while supinating, internal rotation, and pronating, external rotation, of the paw. Pain here is an indication for imaging of the elbow. Another common distractor is that the tendons of origin for the forelimb muscles can pop or jump over the epicondyles under palpation and be mistaken for crepitus or DJD. The shoulder. Extend the shoulder by pulling the entire leg forward, which may demonstrate pain associated with OCD. Flex the shoulder by extending the elbow and pulling the leg caudally alongside the thorax, while putting digital pressure on the biceps tendon to find evidence of bicipital tenosynovitis. Palpate deeply along the medial side of the joint. This is a common location for nerve sheath tumors, and an affected dog will show pain. The rear leg. Toes to tarsus is the same as the foreleg. The hock. Palpate for crepitus, medial and lateral instability. Feel for a fusion in the joint between the gastrocnemius tendon just caudal to the joint. Palpate the calcaneus and gastrocnemius tendon for continuity. The stifle. Flex and extend with the hand just resting on the patella. Detect crepitus due to soft tissues jumping over osteophytes on the condyles. Find the patellar ligament and feel immediately lateral and medial to detect joint effusion. Feel the medial aspect of the joint at the proximal tibia, looking for joint capsule fibrosis or medial buttress effect associated with a chronic cruciate ligament injury. The patella. Luxating patellas are much more common in small breeds of dogs, but it will be discussed here for completeness. With the stifle extended and toes rotated inward, try to push the patella medially out of the trochlear groove. Then, with the toes rotated outward, attempt to push the patella laterally out of the groove. The lateral digital extensor. Feel for a small mass in the craniolateral aspect of the joint, avulsion in young dogs. The cruciate ligaments. The drawer test. The examiner is behind the dog. One hand is on the femur with the thumb on the lateral fibula and index finger on the proximal patella. The other hand is on the tibia with the thumb behind the fibular head and the index finger on the tibial crest. Sharply push the tibia forward and then backward. Guard against creating internal rotation of the tibia, which may produce a false drawer. Any drawer motion is abnormal. Do this with the leg at a standing angle, then flexed, and finally an extension. Cranial drawer. This is most apparent with a completely torn ligament when the leg is in a standing position. Drawer motion and flexion only is characteristic of a partially torn ligament. Caudal drawer motion. Suspect a caudal cruciate tear, usually seen only with significant joint trauma. The meniscus. You may hear a click with flexion and extension movements. If detached, this may limit drawer motion by wedging between the medial condyle and the tibia. The collaterals. Stress the joint laterally and medially. If the joint opens opposite to the stress, you should suspect the collateral ligament injury opposite to the direction that stress is applied. The tibial compression test. With the leg relaxed and your hand on the knee, flex the hock slightly beyond 90 degrees. A damaged cranial cruciate ligament will allow the tibia to push your finger forward from the patella. If there is any question about stability of the knee, or if there is evidence of arthritis without apparent instability, finish your initial orthopedic exam and then sedate the dog to repeat the stifle exam with emphasis on the drawer and tibial compression tests. You may also want to be prepared to take radiographs while the dog is sedated. The hip. Flex and extend the hip with a hand resting on the greater trochanter. Feel for crepitus and assess the overall range of motion. Then, forcefully extend and flex the hip, looking for signs of discomfort. Ortolani sign. This indicates joint laxity and subluxation, and it is usually found only in very young dogs. This is not seen in all cases of hip dysplasia due to the effects of DJD causing tightening of the joint by capsular fibrosis. Although it is an uncommon finding in adult military working dogs in the field, it will be demonstrated here for completeness. The examiner is behind the dog with one hand on the flexed stifle, and the other stabilizing the back, just proximal to the greater trochanter. Pushing with the stifle hand subluxates the hip, and abduction causes a pop when the femoral head relocates in the acetabulum. The thumb test. This demonstrates luxation of the hip. The examiner is behind the dog with the thumb of one hand in the space between the greater trochanter and the ischial tuberosity. The other hand is used to externally rotate the leg. If the femoral head is in the acetabulum, this being normal, the thumb is forced out of the space by the greater trochanter. If the thumb is not moved, then either the hip is luxated or there is a femoral neck fracture. Summary. Carefully record findings noted, especially any abnormal findings in any of the common sites for military working dog diseases, like the hips, stifles, and lumbar spine. Record the location and consistency of pain response to manipulation, non-weight-bearing lameness, muscle atrophy, medial buttress. Your tentative diagnosis should account for each of the above findings, remembering that the dog may have more than one orthopedic or neurologic problem. Critically assess the clinical significance of your findings when forming a diagnostic and therapeutic plan before consulting with clinical specialists in your region or at the dog center for advice on case management. This will not only improve the effectiveness of the consult, but will also lend itself well to training junior officers. Radiograph specific areas indicated by the results of the orthopedic exam. Work up concurrent problems that might impact on the duty performance of the military working dog. Consult with clinical specialists in your region or at the dog center for advice on case management. Follow up with the handler and kennel master about the military working dog's condition, treatment, prognosis, and follow-up.